Thank you, Padmaja ma'am and Sharika, for having me here. I'm a little apprehensive talking about OSS in front of Dr. Fairuz, the maestro in OSSN. Madam, with your permission, I'm going to OSS. As we know, ocular surface squamous neoplasia refers to a spectrum of disease ranging from mild, moderate, severe dysplasia to invasive carcinoma originating from the limbus, cornea, or the conjunctiva. It has this histological picture showing from mild to carcinoma in situ and the keratin pearls. Now, there are certain risk factors for developing OSS. One is the exposure to ultraviolet radiation, human HIV infection, HPV, chronic use of contact lens. Any chronic trauma chance of OSS is there. Similar exposure to petroleum products, some fumes. There is a genetic predisposition and heavy cigarette smoking, as well as male gender in certain areas also. Now, carcinoma in situ, 39% of all pre-malignant and malignant lesions of conjunctiva is carcinoma in situ, and OSSN is the most commonly encountered non-pigmented tumor of the ocular surface. So, it's very important you have to diagnose it early and treat it. So, these are some mimickers seen in these are some mimickers. This is keratoconjunctivitis. This is a pyogenic granuloma or a foreign body granuloma picture. This is a pinguicula. Here you have the pterygium, and again palpebral form, limbal form of VKC. So all these can be mimickers of OSSN. Now, how do we distinguish them? How do you diagnose this? One, from the history, whether it is papillomavirus infection, exposure to UVB, smoking, contact lens, as I mentioned earlier. And if you get a young patient with HIV, always screen them, young patient with OSSN, screen them for HIV. Now, once we have got a patient, suspicious patient, do a thorough slit lamp examination, ASOCT, if you have access to it, go for HROCT and UBM. In doubtful cases, you can go for biopsy. Now we don't do much of excisional biopsy, and we have the impression or exfoliate cytology, but it's not very conclusive. But in case of inflammatory pathology, you can get some inflammatory cells in this. Always check for the regional lymph nodes. That's very, very important. And now this HROCT showing, you can see the hyperreflective epithelium with the thickening and the abrupt transition at the normal and abnormal epithelium. That's very, very important. HROCT for diagnosis and as well as managing OSSN. Now, there are certain characteristics we have to think when you see a case of OSSN. One is the presence of keratin, feeder vessels, intrinsic vascularity, and the pseudopodic-like picture on the cornea, as well as rose Bengal staining, where you get staining of the devitalized tissues also. Now, there are different morphology of OSN, from placoid, papuliform, with different pictures showing different variety, like strawberry-like lesion, and you have the gelatinous type, placoid, corneal OSSN, nodular, mucoepidermoid, and diffuse OSSN. So these are the various variety of morphological patterns of OSSN. Now, how do we manage? Suppose it is localized or diffuse or invasive. The management is different. When it comes to localized, you can go for topical medical therapy. Diffuse, again, you can go for medical therapy, because diffuse, when it is difficult to do a large area of excision, it can result in limbal stem cell deficiency. Again, when it comes to invasive, the treatment is first we can go for chemoreduction, surgery, and may require radiotherapy also. So these are the different modalities of management. Surgical excision, medical, we have the interferons, MMC, 5FU, and adjuvant therapies like anti-VEGF, topical cidofovir, topical retinoic acid, and PDT. So what we do is, when we manage this patient with topical steroids, topical immunomodulators, we also add retinoic acid, which we use in this Inflomax. Now, gold standard for management of OSSN is Shields no-touch technique with 4 margins of clear-free tumor zone, and we followed by intraoperative cryotherapy with a double freeze and slow thaw technique. Is very, very important. Again, if there is a corneal component, you'll have to go for corneal epithelectomy using absolute alcohol, and in case of adherent tumors, you go for 20% sclerectomy. Wound closure is done with amniotic membrane using a fibrin glue. As I mentioned earlier, complications can be limbal stem cell deficiency, symbolifron formation, congenital hyperemia, and scarring. With Dr. Fairuz's permission, I'm playing this video. See, you can see the tumor area is marked here, 4 millimeters tumor-free area, intraoperative OCT is there, and no touch technique, you're removing the tumor, and this alcohol epithelectomy. And the main important thing is after doing the surgery, slow thawing, double freeze thaw, slow thawing is very, very important to the undersurface of the conjunctiva. And is followed by amniotic membrane grafting and using a fibrin glue. But after this, that mapping and sending for histopathology is very, very, very important. You must mark it either on a filter paper. We usually use a suture, sponge comes on which we anchor the tissue, mark it nasal, temporal, up, down, base, everything you have to mark. Because when the histopathology report comes, very, very important, is the margin free or the base free? That is very, very important, and the management depends on that. Suppose there's an ocular invasion, you have to go for enucleation. And in case of orbital extension, we'll have to think about orbital accentration. And these are the medical management molecules we use: 5-FU, interferon, and MMC. Initially, we used to use lots of MMC, but now we have moved on to interferons and 5-FU. The good thing about medical management is it treats the entire ocular surface, and the subclinical cases can also be dealt with. Now, this 5-FU, we give in a dose of 1%. 4 times a day for 1 week is followed by 3 weeks of no medication. And another one thing you have to explain to the patient is always apply Vaseline around the eye or some moisturizer so that the extravasation or spilling of the drops won't produce any necrosis or excoriation to the skin. This patient had forgotten to use it in 1 cycle, and this is what happened. Again, coming to interferon, it's given a compound in 1 million international units per ml, again given 4 times daily till the tumor resolved, and further for another 1 or 2, 3 months. Good things about it's well tolerated, but the difficulty with this is very expensive, and it had require refrigeration also. It can be given intralesion also, and we have seen flow-like syndrome with patients. Compounding of interferon, we draw 1 ml and we mix with 5 ml of the lubricating agent, reconstitute, label it, refrigerate it, and give it to the patient. That's very, very important. Now we have switched, as I said, switched to FFU and interferon. MMC, we don't use it that much because the stinging and redness, allergic conjunctivitis we have observed is more with MMC. Now, combined medical and surgical management is indicated when, that is when you have large tumor, we require a chemo reduction. Give the medical management followed by the surgical management. And after the surgery, I have the histopathology report. If it is base positive, we have to think about radiotherapy. Now, this is a patient seen in our hospital, 75-year-old female. She had come with the gelatinous mass there, and we started her on interferon, and the lesion resolved within 3 months of treatment. It's another patient who came with, again, a gelatinous mass at the limbal area. But initially, the patient didn't respond to interferon. Then the patient came with a result that a history of antiretroviral therapy. Thing is, the patient should be immunocompetent when you have giving interferon. Immunocompromised, the efficacy is very, very poor. So we switched to FIFU, and the lesion resolved. As a case 3 again, this patient had undergone cataract surgery, and on the table, the surgeon suspected a lesion there and sent it for histopathology, and it was CA proven case of OSSN. And this patient started on interferon. But in between, patient developed uveitis. So that's immunity is changed in that patient. In that patient also, we had to shift to 5-FU. It's a corneal OSSN, again resolved completely with the interferon treatment. Again, diffuse OSSN, if we go for a surgery, this can result, as I said earlier, in a limbal stem cell deficiency, large area of conjunctival sacrification, you get result in symblepharon and scarring also. And this patient responded to interferon, and that's 2 months after treatment. Again, a patient with corneal and limbal OSSN responded well to this HR OCT picture. As I said earlier, you can see the abrupt transition from normal to abnormal. So, detect early, treat appropriately. Thank you.
Thank you, Vijay. Thank you so much. With all apologies to Fairuz for what happened earlier, I think we will let Fairuz complete and take questions at the end, time permitting. While Fairuz, with fingers crossed, gets her slide to play, if there are any questions, Vijay is willing to take them.